What would this layer be named? Myocardium, functional, it's really functional and structural significance.
It's the muscle of the heart.
Contains the muscle cells, cardiac muscle cells, right? And this one, epicardium was a function or a structure. Yeah, so it's the outermost layer of the wall of the heart, right? So it's the outermost layer. It is the visceral pericardium. Oops. Go back. And then what would this label be? We didn't talk about it, but pericardial cavity, right? Well, this one would be, and more specifically, which layer?
Parietal.
The parietal layer.
Parietal.
Because this one is also pericardium, and we call it epicardium, but it's also visceral layer. Okay. If you could indulge me, take a piece of paper, just A, B, C, D, E, try to see if you can identify that.
Yeah.
So we hopefully saw some, not all of these. It's really looking at the white blood cells, by the way. I'm looking at the red blood cells, all the platelets, and loss of use. So this is how it's all, but here I'm looking for the leukocytes. Hold on. No one had a chance to try and identify. We saw some of this in lab today, we saw some of it. Well, I saw all, but of course not every single thing. So I today and on Wednesday too. Okay, you want to look at the red blood cell also to compare size, right? Don't just go by what's in it, but also also size. So since you started with A, you said with neutrophils, why?
It has 3 nuclei.
The lobes. It's one nucleus, but 3 lobe nucleus. Yeah. What else?
The granules.
The granule does have granules. You can see them here. It looks mostly red, but you can see a few blues. Good. Go on, take B. Eosinophils. Why is that eosinophils? Bright red granules, right? We compare the 5, you can see that's the bright red granules. What else is another feature of eosinophils you can see there in that image? Bilobe nucleus, you can see that very nicely. What do we think C is? Any other thoughts? It is basophil. Right? We don't see the nucleus because of dark or blackish blue granules. Okay. Well, what is D then? Okay, compare the size. That's a lymphocyte. Or let's compare this size. That's a lymphocyte. And then here a little bit cytoplasm, here a lot more comparatively. Here's what's in kidney shape, right? What would this cell be called? Erythrocytes, and then this guy, that's the thrombocytes, right? Little specks. Blue, maybe thrombocytes. Okay. As he chokes.
Just slowly down.
Okay, any questions? Okay, those got no felt. Sure. Change it. Okay, so let's start with our blood vessel conversation. I know we talked about 3 types of arteries. Did we also talk about 3 types of capillaries? Okay. What are the 3 types of arteries?
I think we stopped right after aneurysm.
Too much. That's where we start. The atherosclerosis. I remember talking about that. Okay, So we'll take on with capillaries. So capillaries are the smallest of our blood vessels. They are one cell layer thick. What cells are they made of? What kind of tissue? Simple squamous epithelium. So they're simple squamous epithelium. They're called endothelium. That's the lining of blood vessels, which is called endothelium. And the tissue is still simple squamous epithelium, right? They are the site of exchange, whether it's gas, nutrients, whether it's hormones, waste products, all pass through the capillaries, whether it's from the capillaries into the tissue or in the reverse direction. So they can be complete lining. We'll talk about those, don't necessarily need to know. There are different types of capillaries, some which allow large molecules, even cells to pass through, like in our bone marrow, like in our liver. Those will allow large molecules, right? They have pores which allow it. And then we have some places which allow smaller, medium-sized particles like glucose, for example. So capillary beds are basically a network of capillaries supplying the tissue. It's not one vessel that supplies an area, it's multiple that come off the blood vessel. Here, the arteriole goes right to these multiple capillaries. They have connections. They're trying to exchange between each cell, basically. Okay? We do have a sphincter, okay, that controls some of the blood flow. So if this was our skin, for example, right, during sympathetic response, what happens to blood supply to our skin? Decrease, right? So here we would shut off this, right? So it just flows through the skin but does not supply the skin itself. Okay? Anastomosis basically means connections. We've looked at a couple of anastomosis. We name them, but we saw them in the heart, right? We saw between the right coronary artery and the left coronary artery, there were some connections forming alternate fluids. So this also allows for that some blockage in one still can try supply each cell. So let's talk about filtration and reabsorption. So in some places, like in our kidneys, we want to filter the blood. We talk about it in the urinary system. So we want things to pass through, and it's by size that they do pass through, right? Are we expecting to find, let's start with the more obvious one, do we find protein? Normally in urine and hence in filtrate. No, we do not find proteins, right? Do we normally find blood cells? No, so they don't allow everything, they control some things, right? So we have two sets of pressures that allow movement of fluid, whether it's out of the capillaries or into the capillaries. The two sets are hydrostatic pressure, and then sometimes called osmotic pressure or oncotic pressure, a lot of times colloid osmotic pressure. Okay? So the best way to think about hydrostatic pressure is it's going to push water out of that heart. So if there's a pressure, hydrostatic pressure in the blood vessels, they're going to push the blood out of the blood vessels. In the interstitial fluid, they're going to push the water out of the interstitial fluid. Hydrostatic pressure. Okay? Yes, water does attract to each other, but there is a little bit of repelling nature as well. Okay? Having said that, oncotic pressure is the opposite. It's actually attractive. So, for example, let's just draw it just to picture it, and then we'll talk about the significance of the difference. And blood vessel. Okay. So I'm going to use HP for hydrostatic pressure. So if it's hydrostatic pressure of capillaries, it's in this direction, whereas hydrostatic pressure from the interstitial fluid will be in the opposite direction. But because of interstitial of fluid outside, it's going to propel the water away from that space. While oncotic pressure will be actually in the opposite direction. Okay, so oncotic pressure, here I put HB for hydrostatic pressure, C is for in capillaries, so I put it as a subscript. While the oncotic pressure will actually attract water in that direction. So oncotic pressure for capillaries. Okay, it's actually going to pull the water. This is because of protein molecules. Okay, protein molecules will attract water. Whereas the oncotic pressure in the interstitial fluid will attract water to that region. IF for interstitial fluid. Okay, so if you see, there are two forces that will push water out, two forces that will push water into the blood vessel. So at the arteriole where the blood comes in, these two will add up to a higher pressure. It's because of this section. So water moves out in the arteriole side, while in the venous side, further away from our blood pressure, from our heart, this pressure is low, so you'll actually have fluid going back into the capillaries. Okay. So just recognize that the picture it's showing here, how it is very visible. So on the arterial side, you're going to have fluid leaving the blood capillary, while in the venous side, you're going to have some reabsorption. Okay. The main difference is this pressure. That's what's different in the two sides of the capillary. Okay. So recognize that as being the case. Okay. But also recognize that this, whatever filters out, is not all reabsorbed. Okay, some fluid does remain in the interstitial fluid, which is what we will need the lymphatics to be present to take the rest of the fluid out. Otherwise, we will have edema developing over time. Okay, because there will always be fluid remaining here, or extra fluid that's not being reabsorbed. That making sense?
So I'm just making sure I understand it. The arterial side pushes the fluid out of the capillaries, also known as hydrostatic pressure.
Come back with you. Got it. Yeah.
And then the venous side is the osmotic pressure, and it pulls the fluid back in.
I'm going to separate the two. So
Okay.
you're correct on the which side the fluid goes through, right? So in the arterial side, fluid leaves. In the venous side, comes back in.
Okay.
All these four are actually happening on both sides. It's just this one is going to be a different amount. So we don't need to know it for this course. It's about 28 on the arterial side and only about 16 on the venous side. So once you add it up, there's going to be a net pressure going in that direction. While in the arterial side, because it is high, it's actually going to push it down. That's separate from this total conversation.
Okay, so they're two separate.
Conversation, they do play a role, right? So, first of all, oncotic pressure will promote fluid to be in that place, and hydrostatic pushes it out from that spot. Okay, that's why we're going to see that interstitial pressure for the oncotic pressure is going to be in that direction, while the hydrostatic pressure of the interstitial is going to be in this direction. In the capillaries, hydrostatic pressure is out of the capillaries, oncotic pressure towards the capillaries. So net movement will depend on P and F. So which one of these is higher? HB IF plus OPC. Okay, it depends on which side, which of this will be higher. If this is higher, fluid will leave. That's what happens in the arterial end. And in the venous end, this one's higher than that, so fluid goes back in.
Okay. Okay.
So it's two kind of different things, right? But they do play a role. And it's really this one that changes in the arterial and venous side. That's why this becomes a smaller total compared to this. The other one, as I mentioned, is what leaves does not all come back to that venous side. Okay, we do need the lymphatics to take the excess fluid away, otherwise we'll just have fluid build up. With the lymphatics, so if you had a lymph vessel block, you're going to see lymphedema taking place distilled to it because there's a block, so fluid, even what enters, it's going to go backwards to the tissue, which is just because fluid always, there is some fluid always being deposited, if you will, into the interstitial fluid. There's fluid moving out, fluid moving in, but they're not equal amounts. There's always something that's going out. So the lymphatics takes it away. Okay, that's the other one we take away from that. And if we have blocks, which we'll talk about in the lymphatic system, this is green to show the lymphatic vessel. If we have a block somewhere further down, fluid keeps coming back, it will not be taken in, so there will be collection of fluid in that interstitial fluid. What is interstitial fluid, by the way? Do we know what those terms we recall it? Interstitial fluid is between the cells, so it's in this tissue, it will remain between the cells. Okay? And then some fluid, if there's osmosis, it moves into the cell, out of the cell. There's always fluid moving. This is not by osmosis, it's because of pressure difference. It moves out of the cell to reabsorb in the venous. Any questions? Okay. So next we're going to talk about a little bit more about this. So most materials are reabsorbed. There is some fluid loss, okay? But then they will come through the lymphatics and then they'll come back to blood circulation. We'll talk about this in the next chapter. We may not get to it fully today. They'll come back to where the internal jugular vein meets the subclavian vein. They'll come into venous, into the blood circulation. Lymphatics that will bring that fluid back. Okay, this is roughly about that in 1 24-hour period. Any questions? Okay, let's talk about veins. So what is the definition of veins? Carry blood towards the heart, right? So what are some differences in arteries and veins? Can we talk about that? Yeah. Sorry, I have 2 classes.
Veins have valves, arteries don't.
Yeah, veins have valves, arteries do not, right? And we'll talk about the significance of that a little bit if you haven't already. Okay. So they do contain valves. They are similar, right? What's the function of valves? Prevent backflow, right? Why do arteries not need a valve?
The pressure against it.
Yeah, because the arteries, it's being pumped, blood is being pumped out in the arteries by the ventricles, right? So they're just being pushed. Whereas in the veins, there's no pump that's actually pushing the blood. So it's like backup. So one goes in front or behind the other one, kind of pushes this along. It keeps coming up. There's some mechanisms we'll talk about what also promotes it. But the tendency, especially in our legs, is for the blood to go back down the feet, right? The valves will say, no, not going back, keep going forward, just keep going. Okay? If the valves are insufficient varicose veins, you'll see that there's pooling and so on will be collection. Varicose veins could be because of valves, it's not the same thing. It just means those vessels have been not elongated, but they've lost their wall consistently ballooning. It's similar to aneurysm, but here it's more multiple places of this opening rather than aneurysm, it's just a one place. So prevent backflow, right? Varicose veins is when they're stretched out, weakened, it's about distorted valves that can cause the vessel wall to distort. Since I mentioned it, what are some ways in which we can keep making sure that the blood keeps moving up?
Compression cells.
Yeah, what will they do?
It squeezes
Yeah, you can do that. If you're not wearing compression stockings, what can we do? Move your feet up and down because the muscle contractions actually will keep pushing the blood. It's not contracting the blood vessels, but they're contracting besides the blood vessels, so they do push the blood upwards towards the heart. And we'll talk about a couple of other. Does anyone know any other difference between arteries and veins? So it carries which direction of flow, whether it has valves or not.
Say for the pulmonary, oxygen or not oxygenated.
Yeah, sure. Structurally, in terms of the wall and the size, if it's the same size blood vessel.
So is it thicker on the arteries?
Yeah, arterial walls are thicker, which means what about the lumen?
Smaller.
Smaller, right? It's opposite in the vein. Thinner wall, but bigger lumen. Right? And we'll talk about that in biology. So next we're going to talk about tissue perfusion. This is supplying the tissue with the nutrients, blood supply, right? So what are some things that can affect it or either increase or decrease? So cardiac output. If the cardiac output goes down, will the blood being supplied with the tissues change?
Mm-hmm.
Yeah, it goes down, right? That is directly proportional to it, okay? But we also have, if blood pressure is low, okay? If blood pressure is low, this pressure will be low, which also, okay, affects perfusion, okay? Less perfusion if blood pressure is low, right? We probably knew if we have hypotension, they can suffer tissue hypoxia because they're not supplying with blood, tissues with blood. Right? While resistance is inversely proportional, right? Think of resistance as something that's kind of pushing back, right? So if we can think of it this way, so 4 lanes of a highway becoming 2 lanes, right? Will that change resistance? Yeah, right? It's the same thing in our blood vessels too. If we change the diameter, that changes resistance as well. Okay? So resistance is inversely proportional to So first one we already talked about, right? Cardiac output. What are the 2 factors that determine cardiac output? 2 main factors.
Ventricular contraction and relaxation.
Kinda. How do we calculate cardiac output? Stroke volume times the heart rate, right? What is stroke volume? Yeah, one contraction, one cardiac cycle, how much blood is being pumped out? Stroke volume, so heart rate, how many times does a heartbeat in 1 minute? Cardiac output is the volume of blood that's pumped out in 1 minute. We talked about that last week. So we're going to pick up on blood pressure. So what is blood pressure again? Yeah, the pressure exerted by the blood on the vessel wall. Right? Pressure exerted by the blood on the vessel wall. Sorry, it's a squeaky spot. So usually we measure the systemic blood pressure, that's the pressure in the systemic arteries, right, as a 2-numbered measurement. Systolic and diastolic blood pressure. Systolic is the first or the larger of the 2, and diastolic is the smaller than the second one, right? What does diastole mean? Relaxation in this case in terms of systemic blood pressure, relaxation of what? More specifically the left ventricle. Left ventricular contraction and relaxation. So systolic ventricular. We generally measure the systemic. We can measure pulmonary. We need to put a little catheter in there too. You have 2 numbers for that. The right ventricle, what we measure outside, that's the left ventricular contraction and relaxation. While resistance is anything that opposes the movement. Right? right? So if there's a high resistance, the blood would have to overcome that to meet the tissue perfusion. We talked about, I'll talk about the vascular, that's where we talked about the diameter. There's another one to it. What's blood viscosity? What's the viscosity of blood?
How much hematocrit there is?
How much of it is it?
How many red, like the red blood cells? The
That plays heavily on it, but how do you describe it first? Kind of the thickness or the density of the blood, right? So if the blood is more dense, will that make it movement faster or slower?
slower.
Slower, right? A lot of us trying to get through that one door compared to say 5 of us trying to get through that same door. Like we get faster, we just can't go fast, right? So that's the viscosity. Turbulence, what do you think of turbulence? Yeah, it's not allowing smooth flow. For example, any atherosclerosis will promote actually turbulent flow, it will not allow what's called laminar flow, it's more smoother. There is some turbulence also closer to the vessel wall. In the middle it's more straight, vessel wall also okay. Turbulent fluid. So let's talk about the viscosity. Yes, the thickness of blood. It's mainly, why did we say it was mostly due to red blood cells? Yeah, because that's the most common cells in our blood, right? 4 to 5 million per microliter, right? How much thrombocytes do we have? It's in the hundreds of thousands, so 150 to about 500,000 per microliter. How much white blood cells do we have? 4 to 10,000, right? So it's a lot less. So this one really doesn't. It's mainly because of the blood cells, but also plasma proteins as well. Publish. If there's a lot of proteins, that's going to make it thicker, okay, and hence slower too. So, what are some things that can influence viscosity? The direct one has to do with the red blood cell count. What's anemia?
Lack of hemoglobin or red blood cell.
Which one? And is it necessarily lack of it? Low, a decreased amount of red blood cells will be anemia. Would that make it less viscous or more viscous? Less viscous, right? There's less cells. Okay. So anemia will actually make it less viscous. While what was the opposite when we have too much red blood cells? Polycythemia. Very good. Polycythemia. Excess amount of red blood cells, that will make it more viscous, which is why we talked about, did we talk about blood doping?
Yeah.
So this is why blood doping is dangerous, because the white blood cells, red blood cells count in that individual is in the polycythemic range. What happens if I'm dehydrated on top of that?
It's like
It's
maple
going to
syrup.
be even higher, right? Because there's less water, which means the cells, the amount percentage by cells will be even higher. That makes it even more viscous, which does lead to thrombosis. What's thrombosis? Clotting, right? It's thrombus is basically a clot. Embolus. Yeah, it's moving clot. So here, even though the viscosity has increased, or rather anemia has decreased, so the oxygen carrying capacity also has decreased, right? So it's a double this thing, that the tissue perfusion will be decreased because of these two. If this was the reason for the viscosity change. Well, resistance, we can talk about more things in terms of the diameter I mentioned. We can alter that. Our blood vessels do alter the diameter to increase resistance or decrease resistance. Another thing that plays a role in resistance is the length of the blood vessel. For example, if there was this, you sent a little bead down a tube, right? And we said, how many times will it hit the sides of the tube? If you had a shorter tube versus a longer tube, which one do you anticipate is going to hit the sides more often? the longer one. Okay, it's the same in our blood vessels too. We do not change this, but the further the object is, further the organ is, there's a higher resistance towards getting to getting to the organ, okay, or structure. Okay, so so resistance increases with vessel length. As you travel further, the resistance higher. Okay, while diameter, which one do you think will increase resistance? Smaller diameter or a larger diameter? Smaller diameter, right? So it's the opposite here. The resistance decreases as the diameter increases. Right? So these are a couple of things that play a role in resistance. So it's really viscosity, it's the length of blood vessels, and the diameter of the blood vessels. The last one is turbulence, and it's easier to show turbulence or to demonstrate or speak about it in the arteriosclerosis, right? So here's the plot. This whole thing should not happen there. It should have been a nice circle. So here it's going to cause turbulent flow. Right? That's going to reduce perfusion. It's irregular surface that can cause turbulence. The next thing I want to talk about is how our blood pressure changes as we move away from the heart, right? So we consider roughly about 120/80 to be the pressure of blood leaving the heart, right? The further it gets, it's going to drop, and we also will lose this difference once we get to the arteriole, okay? We have a constant pressure, we do not have a change in pressure. That's one. And what do we notice? The biggest change is where? It's actually at the arterioles. The biggest drop is at the arterioles. Okay? So it does decline as we move away from the heart. The biggest decline is arterioles. Once we get there, it really does not experience the changes in contraction of the heart or relaxation. It becomes consistent, and then it does reduce with the large veins having the lowest blood pressure. What's pulse? What is pulse? It kind of is, but if you do not feel the contraction here, right? Because the contraction, sure. So, when the heart contracts, it relaxes, right? We've just learned, or we probably knew, the pressure does change, okay? This pulse happens at the same time the blood is moving because of the contracted. During contraction, we send this pulse of the wave because of the higher pressure. Okay, that's what we feel. So when we count pulse, can we relate it to the heart rate as well? Yeah, it should be the same. Yes, there are some times where there is a disconnect. Okay, when there's blood vessel problems here, if there is a loss in pulse rate, that means there's an issue with the blood vessels. So pulse is that throbbing effect of feel, which does accompany with the heartbeat. So we can count pulse rate, that's what we generally use, and we say that's the same as the heart. Pulse pressure, on the other hand, is basically the difference between systolic and diastolic blood pressure. So for that individual that we looked at, 120/80, that systemic blood pressure is. Pulse pressure is 120 minus 80, which equals 40, right? So that's the pulse pressure is the difference. And it says here decreases as the distance from the heart increases, right? We saw this in the chart. Pulse pressure is this difference. It's 40 here, or about here it's not, right? It's only about 20. 80, red, 60, green, it's only 20 there. So it's decreasing, the pulse pressure decreases as we get further away from the heart. Make sense? Right, transfer their way, so they do not feel the difference in pressure changes. So venous blood moves at a low pressure, so we need to make sure they're moving. So there are some things that help, right? We talked about the valves, of course. Well, let's talk about, we mentioned this muscular pump. This is when adjacent skeletal muscles next to blood vessels, so the veins here, are contracting and relaxing. They're going to push on the vein. They're contracting and relaxing. So that acts like a pump that does keep moving things towards. Okay. The valves will prevent blood from going back down. The respiratory pump, let me just ask a couple of questions to make sure we understand this. So when we inhale, okay, that's blood, air moving in. What's happening to the volume of the chest? Increases. Does anyone know, just before the air actually moves, what happened to the pressure in the chest? It actually drops. If you've experimented, if you have an unused syringe, just move the plunger halfway, cap one side, move the plunger out. Okay, you're going to feel a sucking pressure in that. Okay, so when volume increases, pressure in that chest cavity decreases. That acts as a pump or a sucking kind of effect on the blood on the veins. It's going to pull the blood from the periphery in the veins towards the lung, towards the chest, really. Okay, which in turn means it's pulling it towards the heart. Okay, that's the respiratory pump. It's the negative pressure created during inhalation that will pull blood towards the chest, towards the heart. Okay? That's that negative pressure. We're going to talk about this in the respiratory system. I'll expect us to be able to list it in the correct order, sequence, what happens, what is involved. We'll talk about that, make sure. It seems like we understand the principles of it, and we'll go through step by step. Okay. So, next we're going to talk about how do we regulate blood pressure. Okay, so we want to make sure blood flows properly. We want to be able to affect it if needed. So in terms of auto-regulation, whenever you hear that word auto, you think about automatic. Okay, so if blood pressure decreases to a certain organ and nothing's affecting it, what it'll do is try and get more blood flowing to it. Okay, it can self-regulate there. Okay, we can also have our nervous system input. Right, what does systemic or sympathetic nervous system do to most blood vessels? Constrict, right? So that one decreases blood pressure. Okay, so blood flow decreases. We'll talk about sphincters. It will also cut off sphincters to certain pre-capillary sphincters to certain organs, right? In terms of this endocrine mechanism, what do we think is happening? Hormones, right? We talk about the sympathetic hormones, but there are others going to be special. When blood pressure goes down, we're going to introduce it here. We'll talk again about them in the urinary system, because it really works together with our urinary system to truly work. So, auto-regulation is immediate and localized changes. They try to adjust blood flow to the needs of that organ, okay, without having to involve the brain. So if tissue oxygen decreases or CO2 increases, we're going to open those sphincters that will allow more blood to flow to those capillaries, hence bring in more oxygen or take away the CO2. And these are auto-regulations. So we have localized without the involvement of the brain or the endocrine system. While the neural system involves our nervous system, sympathetic versus parasympathetic, right? It is a reflex. So what are the 5 components of the reflex arc? What's first? sensory receptor, afferent pathway, integration center, efferent pathway, and then the effector, right? So something has to sense this change, okay? We do have receptors, okay? We have baroreceptors. Does anyone know what a barometer is? Measures the pressure. Usually we measure outside pressure. We have these mechanoreceptors in our body that will detect changes in pressure, whether it's stretch different. Okay? What does chemoreceptors do? Chemicals. Here they're monitoring, I don't know if I mentioned it, we are more sensitive. So our chemoreceptors can respond to three things. They can respond to oxygen, CO2, and the acid-base balance. Which one of these three is the strongest influence to our brain? It's actually CO2 rather than oxygen. Oxygen is actually the least of the three. Okay? So high levels of CO2 will trigger it much faster. Acidosis next, and then only low oxygen will trigger our brain to beat faster. So we are more sensitive to oxygen, CO2 level rather than oxygen. And then we have, as part of the integration center, it's going to be the medulla, which will dictate what rate and rhythm we will be here in the case of blood pressure, but it's the same for the respiratory too. They combine more, right? Because we want not just the output, cardiac output and peripheral resistance to change, because that will affect the blood flow, but we also want the content to change too, so that we do have that effect as well. Right? Here it's mainly arterial pressure, and then the blood gas, we talk about CO2, oxygen, and acid balance. So baroreceptors, where are they found? Baroreceptors, we have a couple of them at the aortic arch. So today and last week, we may have noticed, we'll look at it next, might be the Wednesday or Monday. The aorta goes up, there's a little arch, and then goes down. Okay, we have some receptors on the arch, so it's easier to measure when it's turning, right? We have some receptors there. We also have receptors, what's called the carotid sinus, where the two, the common carotid will split. There's receptors there too. Those are the two main ones. We do have receptors in the right atrium, but this is more sensitive to pressure increases rather than decreases in blood pressure. Okay? So if pressure is high, these baroreceptors will keep letting the brain know the pressure is high, right? So then we will inhibit the vasomotor. So whatever is causing blood pressure, blood vessels to constrict, we will inhibit that, so they will dilate. We'll also stimulate the cardioinhibitory. So which is the cardioinhibitory center? What's going to inhibit our cardiovascular system? Which will stimulate it, which will inhibit it.
The parasympathetic.
Parasympathetic will inhibit, right? So it will also cause the parasympathetic centers to fire more because here the pressure is too high. And it will also inhibit the cardiac rhythm, which is basically sympathetic center, sympathetic system, right? Both will try to decrease the pressure. But if we have a low blood pressure, the opposite will happen, right? So we just look at it first. So the chemoreceptors, they can sense CO2 changes, change in pH or oxygen, but we are more sensitive to increase in CO2 than the other two. Right? We are sensitive to increase in CO2, decrease in pH, decrease in oxygen. Why is decrease in pH very similar to increase in CO2?
Because CO2 will make your blood more acidic.
Yeah. Does anyone know what it does directly? It does. CO2 in blood makes acid. We'll talk about this in a later chapter 2. So CO2 plus water is this molecule. Does anybody know what this molecule is? No? It's carbonic acid. Okay? And what do acids do? How do we define an acid? Yeah, it's going to dissociate to give H plus ions. I'll take this bicarbonate ion. So, high CO2 means high H plus ion, high acid, which is, should I say low pH or high pH? Low pH, right? It is low, acids are, but low pH bases have the higher pH, right? That's basically why, yes, CO2 is also means that acidosis, but there can be other reasons why acidosis, so we'll try and get rid of the CO2 from our body, right? That's like getting rid of acid, which we'll come back to talk about. Okay? So these mostly affect our respiratory centers, but they do play a role in blood pressure. So they will increase blood pressure because we want blood flow to increase, because we want to get rid of that CO2. Okay. The next one is talking more specifically with our nervous system, right? So cardioaxillary centers, those are sympathetic that we already mentioned. Cardio-inhibitory centers are our parasympathetic. So they decrease cardiac output. Cardio-stimulatory centers or axillary centers will increase cardiac output. Any questions so far? Okay, let's talk about the endocrine. Okay, there's a lots of hormones which will play a role. Here it's an introduction. I'll put some of them we'll talk about here, some go in detail in the renal system. Okay. Epinephrine, norepinephrine we should be aware of. What is it secreted by? Adrenal medulla, right? So it enhances which of these two systems? Sympathetic system, right? It's considered short term because we're talking about minutes rather than hours to days. Okay, that's why it's short term. Nervous system is seconds, right? Here it's a little bit longer, but it's more minutes, but it's not hours or days, whereas these will take a little bit longer. We'll talk about these. So that one we should know already. Okay, we'll talk about details shared at the moment. So right now we'll talk about the effects. We'll talk about where they come from in the kidneys. Okay, angiotensin 2 has a couple of effects. One of them is to vasodilate. Okay, so it's going to vasodilate. Let's say vasoconstriction. Sorry. Okay, so when it vasoconstricts, what will it do to the blood pressure? Increases, right? That's released when there's pretty much everything here will increase blood pressure except one. Okay, the only one that will not increase blood pressure is this one. This actually decreases blood pressure. Atrial natriuretic peptide. Where do we think it's being released by? Atrial natriuretic peptide. Atrium, right atrium. We're going to talk about how there are some receptors in the right atrium. This one is released when the blood pressure in the right atrium, which is, where is the blood coming from to get to the right atrium? The body, right? And there's a lot of blood coming from the body that translates to high blood pressure as well. But it stretches the right atrium that releases this one will cause vasodilatation. Okay, this is the only one. This one we'll talk about kind of like an extra step. Okay, but this is the only one that will decrease blood pressure. Two ways. One, it's going to cause vasodilatation. Okay, and we'll talk about the long-term effect in a second. Same thing, angiotensin also has a long-term effect, which is through a cascade we'll talk about. Okay, but this causes vasoconstriction. This causes vasodilatation. Okay, when we talk about long-term, we're trying to increase or decrease. It could be the blood volume. Okay, we're increasing or decreasing, changing the amount of blood volume. So if we increase the blood volume, what will it do to the blood pressure? If we have more cars on the road, it'll increase blood pressure, right? If we have less of it, it'll decrease blood pressure, right? So all of these long-term effects to increase blood volume. What does anti-diuretic hormone do? It acts on the kidney, yep, that's a long-term effect. What does it do? Anyone know? Remove the water in the urine, right? So there's less water in the urine, more concentrated, so you're conserving more water, okay? Angiotensin 2 acts through aldosterone, also stimulates the antidiuretic hormone. It doesn't have a long-term effect by itself. It will stimulate aldosterone release. It will stimulate antidiuretic hormone. It will also stimulate our thirst center. So it doesn't have direct response, but all of which will result in a higher blood volume, which then will increase blood pressure. Does anyone know what aldosterone does? Or where it's released from? We talked about aldosterone release somewhere. But it's confusing. Yeah, where? You're close enough. It's called a mineralocorticoid. Where is it released from? It's from our adrenal cortex. Right? It's released from the adrenal cortex, similar to cortisol, but it's also released from our adrenal cortex. Here it will promote, anybody know what it does? It promotes sodium reuptake in the kidneys, which means if sodium is taken back, is being absorbed, reclaimed, water comes with it. Right? Whereas ADH directly invites or promotes water. Here it's indirect. It actually will absorb sodium. We'll talk about smooth the kidneys. That will increase blood volume. How does erythropoietin increase blood volume? What will it do, erythropoietin?
Stimulates the hormone, so it's a hormone to make the red blood cells.
Yeah, so if you have more red blood cells, we're expecting higher blood volume. Here, atrial natrium. What's natrium? Reference to salt, right? Or what more specifically in salt? Sodium. Natrium is sodium, right? Here it will block the reabsorption of sodium in the kidneys. So if sodium is not reabsorbed, less water is reabsorbed. Okay? Blood volume decreases. Remember, this is the only one that will decrease blood pressure. All of the others will increase blood pressure some way or the other. Okay? This one will prevent sodium from being reabsorbed, which means less water is reabsorbed or more water is lost in the urine. So blood volume decreases, blood pressure decreases. Okay? It does have two ways. This one's a direct influence on the blood vessel. It causes vasodilatation, which does decrease blood pressure. Okay, some more things I thought that in the urinary system. So let's actually talk a little bit about this. Let me introduce the first part. So aldosterone versus angiotensin. So renin's released by our kidneys. That's going to cause angiotensin 1 to be released. Okay, which gets converted to angiotensin 2 by an enzyme called angiotensin converting enzyme. In short, ACE. Have we heard of ACE inhibitors? Who gets ACE inhibitors? Not asthmatic patients. Hypertensive patients, right? It's going to block this angiotensin 2. Because what does angiotensin 2 do? One of the things, it's going to increase blood pressure by vasoconstriction. So we reduce the vasoconstriction, which in turn will reduce blood pressure. That's why we put it here. Right? So, it's renin's released by our kidneys when blood pressure to the kidneys is low. Blood pressure to the kidneys is low, that means blood pressure to the whole body is low, right? It's going to cause angiotensin 1 to be released, but angiotensin 1 gets converted to angiotensin 2 by this enzyme. This enzyme has to be released by the lungs. So if you heard of ACE inhibitors, they are blocking this enzyme, which means the angiotensin 2 number of the amount of angiotensin 2 will be less in that person, which means they will not vasoconstrict. If they do not vasoconstrict as much, then they will vasodilate, which also means blood pressure decreases, right? That's all right there. Okay, so immediate effect of angiotensin 2 is to increase cardiac output, but also cause constriction of our blood vessels, which will result in an elevated blood pressure, systemic blood pressure. Then we'll talk about what it does in more detail in our kidney. It will also stimulate ADH release. It will also stimulate aldosterone release, and will also stimulate thirst receptors. All of these are long-term effects. All of these will increase blood volume. If blood volume increases, what does it do to the blood pressure? Increase as well. Okay, we'll come back to this part. Talk more about it, but actually where it happens. Well, antidiuretic hormone, what is it produced by? Produced by hypothalamus, stored and released from which part of the pituitary gland? Posterior pituitary gland, right? Posterior pituitary gland does not produce its own hormones. It's antidiuretic hormone, and which other hormone? Oxytocin. They're both produced by the hypothalamus. They're just stored in the posterior pituitary gland and released, right? So they'll release when they can directly be released when the blood volume decreases. Hypothalamus can sense that. They can sense blood volume. They can also sense the electrolyte balance. When might the electrolyte balance or concentration, solute concentration increase? When we are dehydrated or when we are well overhydrated? Dehydrated, right? We're moving water, which means the solute percentage of solute will be a higher number. Right? So those all will also cause antidiuretic hormone release. And we mentioned angiotensin 2 also cause ADH release as well. So what its effects? Two effects, right? Short term vasoconstriction. Again, remember all these hormones will try and increase blood pressure, except one, right? Which was the one that decreases blood pressure that we talked about? Yeah, very close. Atrial natriuretic peptide. Right? That's the only one that will decrease blood pressure. Everything else will increase blood pressure. So if we don't want it, we can block that. Right? That's what we do in one of the treatments for hypertension, base blood pressure. Is an ACE. Right? block something, it will increase. Right? So the short-term effect of ADH is vasoconstriction, long-term increased blood volume by reabsorbing water in the filtrate and hence passing less volume. While erythropoietin we already talked about, it really will stimulate red blood cell production. This happens. Does the kidneys, are they able to sense that the red blood cell count is low? No, right? What can they sense? Are erythropoietin released in high altitude? Yes. Did the blood cells decrease suddenly? Decrease in what up there? It's pressure, but what is sensed by the cells? Oxygen content, total oxygen content is also low, right? When pressure decreases, the volume, the amount of oxygen is also low. So that's what's sensitized, and that's what's been stimulated. So it's the oxygen content to the kidneys. If it's low, kidneys will release erythropoietin. Erythropoietin stimulates red blood cell production. Where is red blood cells produced? Bone marrow. All blood cells are produced in the red bone marrow. Right? If that happens, the blood volume also increases necessarily. Atrial natriuretic peptide is the only one that's released when the blood pressure is high, and this will decrease blood pressure. Okay? These are located especially in atria, especially in the right atrium. Okay? So there's a lot of blood that comes back in the venous system. This will cause stretching of the heart. We use this to diagnose as well as monitor heart failure. How would this be a good tool to monitor heart failure? So what happens in heart failure we talk about? Backing up. So if the right ventricle, doesn't matter which side, okay, right ventricle is not pumping or the left ventricle is not pumping, where does the blood first go next to or backs up into? The atrium. Okay, those atrial muscles will be stretched, they're going to release ANP. We use it to monitor as well as diagnose as well as monitor treatment and cardiac failure. Okay, you can see. First of all, diagnosis when the ANP levels are high, we give treatments. If they're coming down at a good pace, then treatment's good. If they come down and then start going up again, treatment's right for treatment's not. Okay, so that's what we do use. So this is the only one that's released when blood pressure is high. What it does is to decrease blood pressure. Okay, so direct effects, it's going to cause. Here, so blood volume, it also causes vasodilatation, short-term effects, but others are long-term effects. It will reduce thirst, it will block ADH and aldosterone release, it will promote the loss of sodium, natriuretic sodium, and hence water in the urine. If more water and salt is lost, we are losing blood volume. Okay, hence blood pressure going down, we're losing blood volume. Okay, it also causes, because in the short term, it causes vasodilatation, which reduces blood pressure as well. So let's talk about hypertension. This actually has been backwards and forwards. The latest one is 140, it's over 140 and 90. Previously they actually reduced it, and then they found that nobody was within the normal range. Okay, that's what happened just about 5 years ago. It wasn't even that long ago. If you heard about it, they actually brought it down to 120 over 70 as we know. But they brought it back up. They only diagnosed it as 140 over 90 is considered hypertensive. Okay? It can be either, whether it's systolic raised, diastolic, or both. Okay, it's considered hypertensive. We call it essential hypertension. We'll test other things, especially if it's a young person. We'll make sure that cortisol levels are normal, right? Because if the cortisol levels are raised for different reasons, then blood pressure is also going to be raised, right? But that's not, it's not essential hypertension. It's what we treat for anyone who doesn't have a outside cause besides the sympathetic nervous system. It's basically an overactive sympathetic nervous system that causes essential hypertension. Okay? Hypotension by definition is below 90 systolic and 60 diastolic, right? And then even further lower would be signs of shock. What is the definition of shock? Poor perfusion, very good, right? So it's poor tissue or decreased tissue perfusion. One of the reasons is blood supply will talk in the top of our conversation. So there are three things, right? Blood vessel, blood, as well as heart problems that need poor perfusion. What's orthostatic hypertension? You heard that? Yeah, when they're lying down, standing, all of us will have a slight drop, and then what we should have is actually blood pressure going for much higher than it was when we were lying flat. Okay, these individuals, they can be dehydrated or individuals that have lost control of their sympathetic nervous system, and generally elderly, they actually will drop and remain dropped. Okay, so when they get dizzy, they fall, they hurt themselves too. So vasodilators will promote vasodilatation, as it says. What will it do to our blood pressure? Decrease it, right? Vasoconstrictors will increase blood pressure. Okay? They also will dilate those peripheral capillaries, which we talked about in terms of autoregulation. I can also do that. So shock. These are the different types of shock. Shock basically is decreased tissue perfusion, right? I've given a few different types of shock. Hypovolemic shock, which basically is the volume of blood is decreased, right? It could be multiple things. I've given some examples here: severe burns, hemorrhage, vomiting, diarrhea can also lead to hypovolemic shock, right? Vascular shock, this is because of the blood vessels are not able to retain integrity. They actually will vasodilate and they shouldn't, right? Anaphylaxis can cause that. That's what it causes, right? When you dilate the blood vessels, blood will not stay in the blood vessels and blood pressure drops. Septicemia can also lead to shock. Shock, by definition, we also have what's called a septic shock as well. While cardiogenic shock has to do with the heart, right? So if I suffered a major heart attack, I could go into cardiogenic shock, which I'm not able to pump the blood, so blood volume and tissue perfusion, or blood pressure and tissue perfusion will decrease. So here are some responses to hemorrhage, right? As you probably would have heard. So what's hemorrhage?
Bleeding.
Bleeding, right? So when we bleed, the first thing that we want to do is maintain blood pressure, right? Or the body wants to do is maintain the blood pressure, right? So it's like shutting off certain organs and just keeping certain organs in with adequate blood flow, okay? So you start to see the decline very quickly when you have significant blood pressure, okay? But we'll try to increase blood pressure initially when there's a bleed. See, if you get cut, you measure somebody's blood pressure, they'll be high on the pain receptors, right? Also, it's a response to bleeding as well. But long-term goal will to restore normal blood flow in you. Please leave it around the stop. Take a break. Okay. There's only two more slides. Okay, so in terms of blood vessels, we actually have a whole chapter on the names. Most of them, arteries and veins, they're the same names. There are a few exceptions, right? What about the blood supply to our head? What artery takes blood to the head?
Right.
Carotid, what brings it down? Jugular. What about the heart we talked about? What blood vessels supply the heart muscles?
Coronary.
Coronary arteries. Where is blood coming back? Cardiac veins, right? So mostly it's the same. We'll talk about this and that. Either this week for Wednesday students, next week for other students, right? But others are different. And the same with the large vessels too. What blood takes blood away from the left ventricle? Aorta. But what brings blood to the right ventricle?
Superior
Right
vena cava.
atrium, sorry. Superior vena cava and the inferior vena. Those are again different names, but otherwise it'll be very similar. We'll talk about this in lab. And then some vessels change name when they go to different spots, especially the one in the arm. It's the same blood vessel, it becomes subclavian, it becomes axillary, becomes brachial artery. Okay? In the leg it's not as distinct because there's a split. The external iliac artery, the same vessel will be called femoral artery when it passes the inguinal canal. We'll talk about that as well. So we talked about right-sided failure, left-sided failure. Where would fluid collect in right-sided heart failure?
Right-sided is pedal edema.
Yeah, more in the legs, or if they're lying down, you want to examine their back, sacrum, right? Left-sided failure, more
Pulmonary
in the
edema.
lungs, right? So again, but back in the blood. Questions? Let's take a little break, and then we will go on to our next heart failure chapter.